Hello guys, welcome back. This is Dr Ranjith, your pathology educator at Unacademy. So here we're going to resume the FRCpath question discussion. We have done two videos previously. We have discussed a couple of questions there. We had gone with predominantly hematology. There are a few students who are asking for more hematology questions. So here we have two more hematology questions, especially focused on FRCpath. It might be helpful for your undergraduates as well if you're going to have the image diagnosis. The discussion part might be a little bit overwhelming for my undergraduate. So I would say this should be linked for postgraduate students only. Fine. And we have also a series going for postgraduates in the YouTube called as your pathology nuggets, which are case discussions, which are not MCQ discussions, pure case discussions which came in the lab. And apart from that, we have put on lots of classes meant for postgraduates in the Unacademy app. You can download the app with the link given below. You can use the code PathoCups to unlock all these classes, and all of them are free of cost. So it's only for postgraduates. We have completed cervix, endometrium. We wanted to do ovary, but we got diverted into lymphomas. We have did lymphomas. We have discussed lymphomas in detail. So when you have time, if you want to become a hematopathologist, this could be a very good place to start. Obviously, you will build it more onto this and you will learn more as well. Fine. So and that will be an interactive session if you're live and available, and you can watch them anywhere. You can download the PDF, you can save it in your laptop as well for future references. Fine. Okay, so today's discussion, we are not going to discuss about cases. We are going to discuss about two MCQs. Both of them are from HemoPath. Both of them are related to bone marrows only. Fine. We go to the first one. The first one is a pretty simple one. The second one is where I'm going to concentrate more on. Fine. Okay, so an image and you have a question. Fine. First, we'll read through the question. I'm sure once you looked at the image, all of you must have made your diagnosis easily, right? So look at the image. The microscopic appearance of a bone marrow biopsy in the following picture is most consistent with which of the following conditions, right? First, I don't have an age here. So I'm sure all of you know how to determine the cellularity of a bone marrow. Whenever you are given a bone marrow, the first and the foremost thing I want a postgraduate to look at is the age. So the general rough cellularity, what is given is it's 100 minus age. So that's the rough cellularity of a bone marrow, right? So let's say for an example, a patient is a 40-year-old person. I would expect 100 minus 40, 60% cellularity, right? An approximate differentiation, that's all. Doesn't mean that a 0 age person should have 100% cellularity and 100 years will not have any cellularity. It's an approximate. In the middle adult, I'm going to use this 100 minus age to tell me a rough cellularity, right? Though I don't have the information here, let's consider it a normal adult. Let's take 50%, 50 years old adult. In that case, definitely my cellularity is very less, right? I'm sure that you will accept me that you won't take a biopsy for a 95-year-old person, right? The cellularity is like maybe 10% max of the entire bone marrow space. I have only one bone marrow space here. This is a trabeculae. This is a trabeculae. In this bone marrow space, maximum I can have a 10% cellularity. Whatever age I consider, 10% cellularity is definitely less. Lots of your fat adipose tissues replaces cellularity, right? So I'm going to look for something which I'm going to call it a pancytopenia or an aplastic anemia in my head. That's what my preliminary diagnosis here. We have to obviously work it out the case and come to a complete diagnosis, right? So look at the options. An acute leukemia generally will not have an hypocellular marrow, right? There are definitely hypocellular AMLs as well as hypocellular MDS. I'm not going with the rarity. Those are just 1 or 2% of the entire thing, right? But 98 to 99% of the acute leukemias will have and should have an hypercellular bone marrow. There are two things called as subleukemic leukemia and aleukemic leukemia. When I will call it subleukemic is, both of these are in respect to the peripheral smear, not the bone marrow. If the peripheral smear shows less than 20% and bone marrow shows more than 20% blast, or the peripheral smear shows no blast and the bone marrow has blast, I call them subleukemic and aleukemic leukemia. Whatever be the condition, acute leukemia predominantly will have a hypercellular bone marrow only. Hypocellularity, as I said, can be there in hypocellular AML or an MDS. So rare diagnosis, fine. Blood loss. Again, we have patients with an acute blood loss. What do you think your bone marrow will do? It will compensate, right? It has to compensate for the blood loss, so it has to undergo hyperplasia. So that also will have an hyperplasia, fine. Third, a bone marrow transplantation following normalization of blood counts. See, the second part is more important. I can have a bone marrow transplant. So for example, I'm doing bone marrow transplant today. Next week, I'm taking a biopsy. It might have this appearance. Because what we do pre-transplant is I irradiate and make my bone marrow completely empty, right? That's what we do, right? So bone marrow transplant after normalization of the counts, which means peripheral blood, and then a bone marrow transplant 2 months later, the PS, hemoglobin, WBC, platelets, everything is normal. I am right in saying that by that time it is normal. Undoubtedly, you should have a very, very good cellular marrow, right? So it has to be a cellular marrow in this condition as well. Once normalization of count happens, it has to become a cellular marrow, right? Next is ineffective erythropoiesis. See, this part is where you might make a mistake if you are going to look superficially. I'm sure everyone knows what an ineffective erythropoiesis is. If I want you to brush the knowledge, I have to go back to Robbins. You must have read about your thalassemia major. So in thalassemia major, what happens is your the erythroblast keeps dying again and again and again. It's a hemolytic anemia, right? So for any hemolytic anemia, what I'm going to have is I'm going to have a hypercellular bone marrow. So though I call it ineffective erythropoiesis, the bone marrow will be and should be hypercellular. So why do I use the term ineffective? So ineffective term is especially for the outcome. My bone marrow tries a lot. It will be filled with the cells. Also, you must have read in thalassemia, you have something called pseudocautious cells, right? That's sea blue histiocytes. That's because of such an high proliferation in the bone marrow. But nothing comes outside. The end part of the blood is still having less hemoglobin. That's why I call it an ineffective hematopoiesis, right? This also will have a hypercellular bone marrow, but outcome is abnormal there, right? Next option, pancytopenia. Of the 5 options, the only option which might fit into this picture is this. Though we have differences of pancytopenia with hypocellular marrow, pancytopenia with normocellular, and pancytopenia with hypercellular marrow. That's a totally different discussion. We'll discuss it something down the road, right? So all of them can happen, but pancytopenia commonly can have a hypocellular marrow right here, right? So it's a perfect hypocellular marrow, bone marrow, biopsy, and pancytopenia is one of the clinical features which can fit into it. The answer is E. It's a very, very simple one, right? So I'm going to discuss 2 things here with pancytopenia. The first one is my diagnosis of aplastic anemia, because aplastic anemia is a very important one for diagnosis. For undergraduate, it's just enough to call it aplastic anemia, but for postgraduate, I have to grade aplastic anemia, right? There's one commonly used criteria to grade aplastic anemia: severe, very severe, and non-severe. I need both. I need both peripheral smear finding, retic count, as well as I need the bone marrow biopsy. If you look at it, it starts, but first you look at severe aplastic anemia. Most of the common cases will be severe aplastic anemia only. A bone marrow cellularity of less than 25%. In general, I call it, but this also you should keep in mind. If it's less than 50%, if less than 30% of the bone marrow is hematopoietic cells, right? I'm sure what you understand. I'm having a bone marrow, I'm not having hematopoietic elements at all. Very less hematopoietic elements only seen. Other things, it can be serous atrophy or hemorrhage or trabecular only. In that condition, how do I take? Because if it's not a good biopsy, I cannot keep on asking again and again, right? So if it's a difficult to take, procedural difficulty, if I have only 30% of the bone marrow is hematopoietic cells, in that condition, I'll take 50% as a cutoff. Even less than 50%, I can push into an aplastic anemia, provided I have these 2 guys. And 2 of the following, it's only neutrophil count. I don't take the WBC count. For me, the main important person is neutrophil. Less than 0.5 to 10 power 9. I want every pathology postgraduate writing an FRCpath exam to be getting used to your 10 power 9 per liter values. Don't find it difficulty converting it per ml to per liter. It has to happen. Multiply with 10 power 3. That's all. You have to do this because almost every question in FRCpath exam will be per liter. That time you not get stuck. CMR diagnosis per liter. Accelerated phase diagnosis per liter. It has to be per liter only. And I want you to get used to per liter. That's how I'm going to diagnose. Which means, in other words, here the neutrophil count is less than 500 per cubic mm, right? So platelet count of less than 20,000 or 20 into 10 power 9 per liter. It's always multiplied by 1000. That's it, right? Peripheral blood leukocyte count, reticulocyte count. It's the count of reticulocyte and not the percentage. It's the absolute reticulocyte count. Either you have to do manually an absolute reticulocyte count. Maybe we'll see how to do a manual absolute reticulocyte count sometime down the future. Or I should be able to I should have a counter which can give an absolute reticulocyte count. Less than 20,000 per liter. Again, it's going to be considered abnormal, right? And when I call it very severe, the same findings holds true. The only change is neutrophil. As I said, that my main problem in the hypocellular bone marrow is my neutrophils. Other things are to some extent fine. But if the neutrophil drops even more, less than 200. I'm much more worried. I call it a very severe aplastic anemia. Right? Non-severe is something like this image. I have only hypocellular marrow, but I don't have a bone marrow blood peripheral smear values, that is my neutrophil or my platelet count, not fitting into one severe aplastic anemia. It should not be normal as well. If it's normal, I'm not going to do a biopsy, right? What do I mean by here is, okay, less than 25% cellularity, let's say 20% cellularity, but my neutrophil is 1000. 1000 is also less, but not less than 500. That's what. Not meeting the criteria of severe aplastic anemia, then I will call it platelet count of 50,000. It is less, but not for severe aplastic anemia. We use the term non-severe aplastic anemia, right? So these are the terms used for your aplastic anemia: severe, very severe, and non-severe. Fine. So one more thing I wanted to add here is this might be a practically important thing as well. If it comes in a theory, if it comes in MCQ, that might help you as well. See, there's something called as ALIPS, abnormal localization of immature precursors. This is especially useful to pick up case of MDS, because in a myelodysplastic syndrome, in a bone marrow biopsy, you won't have them scattered, especially in a hypocellular MDS, which might become very, very difficult. On a superficial look, it looks like an aplastic anemia only. So when you go to the cellular foci, we saw the cellular foci, if you zoom into the cellular foci, you might have these precursors. You might have these precursors stuck there, in and there, right? How to pick up them? Most of the ALIPS will be in the form of clusters. A single cell can also be there, but these clusters are going to help me a lot. Now I have to look at these clusters. When you look at a cluster, you're having almost nil cytoplasm. Yes, you have prominent nucleoli. That was going to tell me, okay, this is a problematic cluster. Here, the cell is also big, right? Here is a small cell. It's a mature myelocyte or a mature neutrophil. Erythroid, I'm going to say, because of the chromatin color, the blue chromatin, the perfectly round nucleus, right? I have a leukocyte here, which is having a lobed everything, a normal leukocyte, right? So you have to look at these clusters. I want you to make sure for every aplastic anemia you see, please concentrate on these clusters. It might change the diagnosis. You do a marker. If the clusters become more than your 20%, it becomes an AML, right? It's less than 20%, but still I'm going to look for more dysplasias. Can become an hypocellular MDS. Obviously, treatment between MDS and your aplastic anemia is going to be totally different. So for every pancytopenia, don't just diagnose on a low power. Go to the higher power. Look for ALIPS. There will be clusters of immature cell. And if you look for ALIPS, to confirm it is immature, you have to have an evidence, right? Do CD34. CD34 can easily pick up ALIPS, right? These are stem cells. So abnormal localization of stem cells, abnormal localization of immature precursors. This has to be documented. If it is there, I'm going to think of something bad. Might be something serious. My diagnosis can entirely change, right? So this is very, very important while you're evaluating case of an aplastic anemia or any hypocellular bone marrow for that instance. Fine, got it. So first biopsy for today was hypocellularity, right? And I'm going to have one more question. This is more of diagnostic challenge. If you pick up the diagnosis, the answer is very, very simple. Let's see if you can pick up the diagnosis. Okay? Look at the question. Ready for the game? Okay. The microscopic finding of 40-year-old person with HIV/AIDS is shown in the photograph. It's a bone marrow biopsy. As I said that we are going to discuss 2 bone marrow biopsies today. Besides the HIV, the characteristic finding associated which are the most common finding. They're saying that this finding is definitely seen in HIV virus. First, I have to know what finding it is, and if I know what finding it is, then the question is, in which of the other options here I'll see the same finding. That's my question next. Fine. So how am I going to pick up this finding? See, I'm not going to do cellularity. The cellularity is definitely hypocellular. There's no doubt in that. Lots of hemorrhage, I'm having hypocellularity, right? So this is a normal fat tissue. In a normal hypocellular bone marrow, like what we saw in an aplastic anemia, I had fat all over, right? There's fat all over. But here it's not fat all over. Here is fat, plus I have pink areas. Could it be plasma? Might be plasma, but plasma will not go and separate the fat tissue, right? It will be like an accumulation, and then fat will be separate. So these are kind of are there between the adipocytes. This is called as a serous atrophy, or a gelatinous atrophy, or a fat necrosis of the bone marrow. This is a spotter. I want you to pick this up, which means the bone marrow is starving and the fat is undergoing necrosis here. Nothing but fat necrosis. Go back to the first chapter. Can a fat necrosis will be pink in color, obviously, right? There's a necrotic fat or a gelatinous transformation of the bone marrow, or we use the term serous atrophy of the bone marrow, right? So this is called as starvation marrow. This is one of the findings you see them in cancer cachexia. There are lots of causes of serous atrophy of bone marrow. We'll look at them soon, right? Let's have a look at the disease of serous atrophy, fine? So it's nothing but a fat cell atrophy and a focal loss of an hematopoietic elements. There's a deposition of a gelatinous material. That's what makes us look at a pink color in the microscopy, which are basically mucopolysaccharides rich in hyaluronic acid and lacks chondroitin sulfate, right? So it's mucopolysaccharides. I'm sure you must have guessed how to pick them up on a special stain, right? I'm sure you must have done that. So why does this fat cell undergo atrophy? Or what are the causes or etiologies you have to think of in fat cell atrophy? In most of this condition, there's a reversible change. You treat the condition like HIV/AIDS in the question or a cancer cachexia, it will come back to normal, right? I have a big list of conditions whenever you see a serous atrophy of fat. One, and the most important in cancer cachexia, it can also be seen in anorexia nervosa, which means it's starvation atrophy. I am not having enough energy for the bone marrow to progress and to go on. Whatever may be the reason, it undergoes atrophy. It can be infection. Again, you have an entire list of infections can cause it, which means when you put forward a serous atrophy of the bone marrow, there's a hell of work for the physician to rule out what the exact causes, right? They have to do a lot of investigation. It could be in PEM, IDA, folic acid deficiency, anything. Again, reiterating the point that there is no nutrition for the bone marrow to survive, so it dies. Hematological can also be seen focally in aplastic anemia or in any bone marrow suppression, which means even the first case, I can have focally fat atrophy. You have to report that if you see in a bone marrow biopsy. Don't ignore them, just don't ignore them as a plasma. If you find you have a tiny hint of doubt, it is a gelatinous atrophy and not a plasma, do a marker. Simple marker like Alcian blue PAS, that should be more than enough. It can be seen in malignancies as well. Because this is important to rule out, this is important to report, because once you take care of this will cause hypocellularity because it's causing focal destruction, right? Hypocellularity will be there. So if the hypocellularity or the pancytopenia is due to this condition, it can be reversed when I take care of the preliminary conditions, right? So this has to go outside in the report, right? So it's a focal hypoplasia of fat as well as hematopoietic cells. If it is going to involve a significant amount of destruction of the marrow elements, it might cause some problem to the patient, right? An accumulation of a gelatinous substance, like we said that it's in your mucopolysaccharides, rich in your lacking your chondroitin sulfate and rich in the other things, right? So you'll have a pink color. It's not exactly purple, it's pinkish. It's a pinkish serous nature, which looks like a fat atrophy, that's all. This is important for us. It can be Alcian blue and PAS positive, fine. One thing is, I should not miss this, I have to pick it up. The reason I have to pick it up is, since I said it's reversible and there is lots of etiologies which can cause it, so I have to evaluate for those etiologies, that's one. Second, it could be a very superb differential diagnosis for one more pink substance, which can get accumulated like this going in between cells. Exact, right? I can read your mind, it's amyloid. Some of you must have thought as amyloid in the first instance. Though amyloid will be a little bit more denser, will not be so loose and like this, but amyloid is still a differential diagnosis. If you have amyloidosis in the bone marrow, again, etiology is not going to be your protein energy malnutrition or cancer cachexia or infections. It's going to go to myeloma for sure, right? So you should not miss this. If there is a focal amyloid present also, or focal pink color material present, I want you to look at both the differential diagnosis and please apply congruent, and you can definitely see the bireferences under a polarized microscopy. That will help me differentiate. This is important because the management and the diagnostic algorithm in which I'm going to evaluate the patient changes a lot. Second thing is site of a previous biopsy, right? Yeah, that's possible, right? The patient is having a leukemia or a lymphoma. You do a chemotherapy. For the post-chemo response, you have to keep taking biopsies for bone aspirates, right? So the patient has multiple aspirates done already, multiple poking done in the bone marrow. I'm going to try it once more again for evaluation of pancytopenia or low cell counts. This might have a focal destruction of the fat. It's nothing but traumatic fat destruction, that's all right. So how do I differentiate a site of biopsy from other enlisted cause of serous atrophy? If it is a site of biopsy, like I said, there will be a destruction for sure. At the same time, at this site of biopsy, can I say this biopsy is nothing but a damage to the bone and the bone marrow? Yes. So it's a damage to the bone or the bone marrow. Will the bone automatically heal itself? It will heal. When it heals, Will it form a bone formation, a callus? That's nothing but a bone healing, right? So if it is a site of bone previous biopsy, what I'm going to see is, you will see first exuberant callus. We had a last pathology nuggets which was discussing on that, right? You'll have a callus tissue, we'll have bony trabeculae. First thing, it will not be lamellar bone, it will be oven bone. It's going to be crisscross appearance, it will not be lamellated. Second, you'll have osteoblast. Osteoblast will be in excess and also have some pleomorphic cells as well. That's very characteristic. An excess of osteoblastic rimming, a pleomorphic cell in the trabeculae, plus in the location of the same destruction, I have to think, okay, this is not a problem of the bone marrow stroma per se. It's a problem in your bone healing, wound healing process. It's a previous biopsy site. That's all. Serous atrophy can also be picked up on an MRI. Serous atrophy can also have an hyperintensity on an PET scan. So keep that in mind. So you might have a case saying that PET was positive. So you must be looking for some cancer, but what you find is just an atrophy. Don't say that is an incomplete bone marrow done or an inadequate tissue for sampling or reporting. It is possible that the same serous atrophy would have caused the hyperintensity in the PET. So keep that in mind. That should not confound your diagnosis. The final diagnosis simple remains the same. It's a serous atrophy of bone marrow. Fine, great. So what we have done today is, we took two cases. Both of them were in the hematopathology department, right? For FRCpath, we saw two MCQs. One was on aplastic anemia. We saw the differential diagnosis. We saw the how to differentiate them, and we also had a quick peek on ALAP. ALAP is important, especially for if you go to FRCpath 2, when you can have cases. That might be one of the discussions where it might lead to, right? Second, what we saw was, we saw your serous atrophy of bone marrow. Though it's a rare condition, it should not be overlooked. You have to look for them. 2 and Alcian blue positive. It's positive for the pH of 2.5. pH is also positive. Keep in mind these differential diagnoses, which can help in the evaluation and coming to the final diagnosis of the patient. Fine. So thank you for your time. So that's it for today. And as I said, that there are lots of cases and content for postgraduate students of pathology in the Unacademy app. You can download the Unacademy app, use PathoCups to unlock all the free classes, and let's learn together. Fine. Thank you for your time. See you soon in another video. Till then, bye bye.